these three areas. I was talking to somebody yesterday, and the way you pronounce the second and the third anatomical part is pharynx and larynx. It's not pharynx and larynx. If I hear you say pharynx or larynx, I'm going to get Larry to beat you. Okay? Larry will spank you.
I'm kidding. I'm kidding.
It's pharynx and larynx. Notice where the Y and the R are in the end. The oral cavity starts at the teeth and ends at the end of the soft palate. That's the oral cavity proper. Not that that's really relevant to anybody, but the boundaries of the oral cavity are listed there. What forms the roof, the floor, you can pretty much surmise that. In front of the teeth, though, in the space in the lips here is called, inside the lips is called the vestibule. The innervation of the area we've been over, but this just re-emphasizes that the V2, the maxillary division, innervates the upper teeth. And I'll tell you, it doesn't innervate the teeth as one nerve, like the inferior alveolar is part of V3. The inferior alveolar innervates all of the mandibular teeth. As far as the maxillary teeth, there's a posterior, middle, and anterior superior alveolar nerve. A posterior, middle, and anterior superior alveolar nerve, like the opposite the inferior alveolar nerve, right? So that's why when you go to the dentist, they can anesthetize all of the lower teeth, no matter which one they want to work on, by just one injection. If they're going to work on the upper teeth, like let's say a premolar here, then they've got to get the area. They can't just go to one site. They'll stick that needle in here and infuse a little bit, and then move it around and inject a little bit over here on this side. And it's not the nerve is inside the bone. So what they have to do is, so the roots are in the alveolar spaces inside the bone. What you essentially have to do is try to get enough of that lidocaine in there to diffuse up to where V2 is to anesthetize it. A lot of times it's hard to do. If you've ever had a root canal done on a molar, you know, some of those molars have 3 roots. And that medial root, they just can't, it's almost impossible to anesthetize. And that's why I generally hate dentists. I don't hate all of them, but anyway. The vermilion border we've talked about, that's where you suture first. And then the other thing is that when you're trying to remove a lesion on the face, Langer's lines comes into play, but you also want to be able to use the natural creases in the face to hide scars. If you can make a scar that's in this direction, if you can make an incision in this direction, you can hide that scar within the normal nasolabial fold. So a lot of, if you're going to remove something up in the forehead, you want to make it horizontal so that it looks like it's hidden in the wrinkles of the forehead or over in the corner of the eyes. You want to try to use the natural creases of the face to hide scars. All right, the nerve supply of the oral cavity. Here's the illustration where you see the different superior alveolar nerves right here. They're all along this area, the maxilla. They're very hard, they're not that easy to hit. The oral cavity proper is provided its sensory innervation, especially on the buccal area, by what nerve? What? Trigeminal. It's a good bet, if you're asked sensory up here, the answer is trigeminal. Not 100%, but it's a good bet that the answer is trigeminal. Okay, and that's what you see here. And there's the inferior alveolar, it's illustrated right there. All right, now, inside the oral cavity, this is what you see here. The hard palate, I'll show you in the next slide, is under that mucosa, there is a thin bone of the maxilla, the maxillary bone. There are palatine bones that are in the back. And then beyond the palatine bones, that's where there's no bony substrate and the palate is soft. You can move it. All right. From the soft palate, you get the uvula, which hangs down inferiorly. In some people, that uvula is bifid. It'll be forked, which is kind of odd when you see that for the first time. In some people, the palatine bones, the maxillary bones, when they grow as an embryo, they grow in from the side and meet in the middle. So there's a suture line in the middle of your hard palate. In some people, it will overgrow, and you'll see this big ridge in the top of their mouth. It's called a torus, T-O-R-U-S. Okay? I'm not sure the Latin definition for torus, but it's something like protrusion or elevation. Okay? So, and if you look in each other's mouths, you'll probably see one or two people in here, instead of a flat, hard palate, you'll see that big bump in the middle of it. And it runs along this way, which mirrors the suture line.
Did you say yesterday there's a lot of taste buds in the hard palate too?
There are. There are a lot of mucus glands and taste buds. People who get dental appliances, bridges, that have the arch that, put in there, there's a bridge. That bridge covers the hard palate, and one of the things that they'll complain about right initially is they've suddenly lost their ability to taste. Well, you've only lost part of your taste buds, but it's a pretty marked absence of sensation that you actually accommodate to in a short amount of time. You get over that, you don't notice it anymore. Okay. Now, when you look in the mouth, you'll see these two ridges, or two arches here. The forward arch is called the palatoglossal arch. It's an arch that extends from the palate down to the tongue. Underneath that arch is the palatoglossal muscle. That's what forms the arch, is the presence of that muscle.
What's the arch called again?
It says palatoglossal fold up here. You can call it an arch. You can also call it the anterior pillar. And behind it, there's another one called the palatopharyngeal arch, pillar, or fold. And it has underneath the mucosa the palatopharyngeus muscle. These muscles are very small. They're not worth dealing with, but the folds are. Now, the palatopharyngeus fold extends from the palate down into the pharynx. But they form a V there, and that V is the tonsillar bed. The palatine tonsils are in that V. So that's where you would find the palatine tonsils, right there. When when you talk about the gingiva, or the mucosal lining of the alveolar ridges, there are three types, the gingiva. The dentist will refer to three types. The buccal gingiva is that associated with the cheek, the soft tissue, the mucous membrane associated with the cheek. The labial is that associated with the lips. So the gingiva is that in front. And then the lingual is the gingiva on the inside. That's how you describe the gingiva around the teeth, around the alveolar ridges.
What do you mean by inside? Where inside?
On the inside. It's not out here. Okay. You probably ought to know how dentists refer to teeth. They don't refer to them as a canine or premolar. They refer to them by number. Starting on the right, that's number one. The adult dentition, if you have all your teeth, should number 32. So you start on the right, 1, 2, 3, 4, 5, 6, 7, 8, 16, 17, and then back around to 32. So 1 is in opposition to 32.
Is one the wisdom teeth?
You start with the wisdom teeth. Yeah. And this is how they designate, in their medical records, this is how they designate what tooth they work on. In your, if you have somebody coming in with a cavity in the emergency room, which you will have very frequently, tooth pain brings people to the emergency room at all hours of the night and on weekends. You can either refer to the tooth by number or by what it is. The left maxillary canine, just as long as you identify the tooth. Right? And if you don't want to use the numbering system, this, excuse me, this gives you, identifies the type of tooth. You have a medial and a lateral incisor up there as A. And then you have the canine, you have a single canine. And then you have 2 premolars, and then you have 3 molars. So, and they're described right here, okay? You just need to be able to document which tooth you're dealing with in the emergency room. Okay. One of the reasons why is that drug seekers tend to use dental pain as a reason to get narcotics at all hours of the night. They don't pay attention, really. They don't recognize the fact that you're documenting what tooth is the painful one. So it's kind of interesting that you see them on Friday night, and it's like the first premolar, and then they come back on Sunday and they forgot which tooth they told you was painful, and they'll pick another one, and that's a tip-off that you're being scammed when they randomly select teeth. If you're going to have a problem with a tooth, you know which one it is, and it's always there. Okay. Now what we've done here is we're looking at the hard palate. We've stripped off the mucosa. Interesting, it is very hard to peel the mucosa off the hard palate. It's really stuck on there for obvious reasons. Yes, ma'am.
So when you count the, this way, would the third molar be like the back molar, all the way to the back, or would you?
Yeah, if you're going to say the third molar, it would be, you would identify 1, 2, 3. If you're counting the teeth, though, you would use this convention. Okay? And, nobody in Oklahoma has 32 teeth. So you're going to have to be a little bit inventive in how you identify which tooth you're working on. Yeah. So when we look at this view here, there are a couple of things you need to appreciate. There's, of course, where the two meet together. If during development they don't meet, that's a cleft palate. So the maxillary bone not fusing is a cleft palate. And the thing about that cleft palate, you see it goes all the way up to here, right? That cleft palate, this part of your maxilla, this is all maxillary bone, right? So it fuses, it starts out here, it fuses this way. And this little thing right here, you have two little ridges on either side, right? When your nose forms, the nose comes down, and then the maxillary bones come in from the side. So you actually have 2 points where your nose and maxillary areas fuse. That's why you have 2 ridges here, right? So in cleft lip, where the non-union is along one of those, or even both of those lines. That non-union is the non-union of the maxillary bone, and it can extend into the oral cavity. So you've got, if you have a cleft lip, it can extend into and as a cleft palate. During a newborn exam, that is one of the first things you check. When that baby comes out and you have that baby in the incubator, one of the first things you check is you look in the mouth to make sure there's not a cleft palate. Okay? There's a few things you do right at the time of birth, and that's one of them. And it has to do with the cleft palate or a cleft lip affects a child's ability to suckle. Okay, so you have to know that.
If it's because the maxillary bone doesn't come all the way together, how do you fix it? You can't pull the bone together, you just pull the hard palate together to...
No, they do, the surgery to correct lip and palate defects are pretty impressive. They don't pull them together. I don't know if they use bone grafts, but they definitely do skin grafts to bring them together. Now, keep in mind that if you wind up with a cleft lip extending into a cleft palate, you're going to affect the dentition as well. It's not going to be normal. Okay, so here are the palatine bones, these 2 little bones right here on the end, and then these openings back here are into your nasal cavity, right? The opening into your nasal cavity from the back is called the choana, C-H-O-A-N-A. E, if you're talking about both of them, choana. And then off of the palatine bones is actually part of the sphenoid bone are these plates right here. There's a medial and lateral pterygoid plate that serve as attachment points for the different muscles of the tongue and oral cavity.
So what was that, how do you say choana?
Choana.
Choana.
C-H-O-A-N-A-E.
Choana, the opening of the nostril?
That's the opening into the nasal cavity from the back. So you can take, so nosebleeds can occur, from the manual to the digital manipulation right here. That's an anterior nosebleed. You'll see later on today that the arteries supplying the nasal cavity actually enter the nasal cavity from the back, from back here. If they bleed, it's called a posterior nosebleed. The nosebleed, by the way, the grown-up term is epistaxis. Epistaxis. E-P-I-S-T-A-X-I-S. Epistaxis. People with posterior bleeds usually have it because of some type of blood disorder, a blood dyscrasia, D-I-S-C-R-A-S-I-A. Dyscrasia means there's something's wrong. You don't have enough platelets, or you have leukemia, or something like that. People on blood thinners can have posterior nosebleeds. Unfortunately, because the arteries back there are so large that supply the nose and oral cavity, you can bleed to death or asphyxiate from the amount of blood that drains down your throat. So what you do when you have a nosebleed that won't stop is you can pack it. In other words, put like a tampon in the anterior part of the nose, and that pressure, you don't use a tampon, but you see what I mean, it's like that. That pressure helps stop the nosebleed, right? You put pressure on the nosebleed. So to get to a posterior nosebleed, since it's way back there, what you do is you take what are called bayonet forceps. They're long forceps like that. You clip on a string, like the string you tied up the cadavers with yesterday, sort of. You pass it through the nose and into the, past the soft palate, and you see the string hanging down now in the back of your throat, all right? You reach in there and grab the string and pull it out, and now you've got the string going in your nose and coming out your mouth. You can do that with spaghetti too, okay? You tie the tampon to the mouth end of the string and then pull it through, and the tampon goes in and up and blocks the posterior nosebleed. It's pretty easy to do. And again, you don't actually use a tampon. I'm just using that for illustrative purposes.
Does
Did
it
you ever
post?
have your kids do fun things like that just because you knew the anatomy so well?
Do what?
So did you ever have your kids do like fun things like that with spaghetti just because you knew the anatomy so well?
I'm not a freak.
I was just wondering. If my dad was out, I'd be like, that was
Hey,
cool.
Emily, I tell you what, if you, watch this. That's crazy. Kelly, can I borrow a tampon? Watch this. By the way, I wear underwear under my scrubs. She had a conversation yesterday with a physician from Indiana about whether or not I was going commando. What are you people doing? Y'all know what to do?
She said she didn't like the smell of the cadaver lab on your underwear.
That hole right there is called the incisive foramen. It transmits an artery and a nerve that supplies the gingiva of the incisors. We're going to see it later on. Now, the innervation in the blood supply to the hard palate arises or enters the hard palate from these two little holes right here. There's a greater and lesser palatine foramen. You see that greater or lesser palatine foramen? So here are the nerves and arteries that go in, that come out of those foramina. The ones coming out the greater palatine foramen supply the hard palate. The ones coming out of the lesser palatine foramen supply the soft palate. Nonetheless, that's where they are right there. Right here at the back of the back corner of your palate. Now, let me explain how those nerves get there. Here's the nasal cavity right here. They come down inside the bone right there. They've been chipped out of the bone. The bone's been chipped away. They come down and then exit the little foramina right there. Now, this is not on your handout, so let me explain how they get there. This is maxillary. This is going to be V2, right? So you don't have this slide, but this is what I want to show you. here's the the orbital cavity right here. I said V2, there's the inferior orbital fissure. I said V2 traveled in that ridge, that little groove there, and then dove into the bone to come out there to the infraorbital nerve, right? You remember that? So V2 is right there. There's the nose right here, the nasal cavity is right there. Now on this slide, on this section right here, if we look from the outside, there's the orbit right there. The nose is here. So V2 is going to be coming along here somewhere. It crosses right there. There's the back of the maxillary bone, and this is that plate. If you go back to here, that plate is right there. So that's the plate, the lateral pterygoid plate. You're looking at it from the outside. That gap there is called the fissure. And I don't care that you really know that fissure because you never really see it clinically, but that's how V2 gets there. It crosses there and it goes over there. Now, when it's right in here, remember the palatine foramina are right there, right? It's inside of that bone where those nerves descend. It's inside of the maxillary bone where those nerves descend. Here's the fissure there. There's the edge of the maxillary. There's the lateral pterygoid plate. There's the pterygomaxillary fissure. Inside that bone, right there, you see that blue thing going down? That's where those nerves run to get to the hard palate. It's a very complex little piece of anatomy there. Yes, ma'am.
You said that the maxillary nerve goes through foramen rotundum, correct?
Uh-huh.
So where does that come into play?
There's foramen rotundum would be right there. As it exits the interior of the skull, it crosses that fissure and then enters the maxillary bone, runs at the base of the orbit, and then comes out the infraorbital foramen. Okay? Now there's a ganglion that sits right there, that hangs off of there, that provides visceral efferents, that's where they synapse, the motor ganglion, to the hard palate. Those fibers come down and get on the hard palate from that ganglion. You know you have the glands and taste buds. Remember, the visceral efferents of the oral cavity are accompanied by taste fibers like the chorda tympani. The same thing happens up here on the top through that ganglion there. That ganglion is called the pterygopalatine ganglion. Pterygopalatine ganglion.
Why don't we have this slide, just out of curiosity?
Because last night, about 10:30, when I was going over this lecture, I said, you know, you really can't understand it just looking at that. So I'm going to add these 3 slides off of Google Images onto your lecture. And at 10:30 at night, Amber was not by my side to upload this to D2L. So that's why you don't do it.
All right. Yes.
I can get it to you, but it'll be after the lecture. Okay. Any questions? You're not going to find, I mean, in other anatomy classes, we go in and dissect the pterygopalatine ganglion, but why? This is not something that you typically are going to be dealing with ever in your life. As long as you understand that V2 is there, providing sensation, providing visceral efferents, and transmitting taste from the hard palate, that's really all you need to know. All right. You do have this slide. All right? And this shows, now, let me orient you to this slide right here, because it's really goofy. What they've done is that in this slide here, you see the septum. the nasal septum, so they made the cut so that you're looking at the septum, right? So what they did was they detached the septum, what they did in this line was they detached it and they folded it up. So that's what this line represents. That's the septum there that's been folded up. Normally, you would fold it back down to enclose that side of the nasal cavity, right? It's interesting, this picture, because it illustrates the arterial and nervous supply really well with this stupid folded up image. To get into the nasal cavity, all we gotta do is go through that hole right there. You see that dark spot? That hole will get us into the nasal cavity, the back of the nasal cavity. There's the nasal cavity right there. If we go through that hole, we can get to it. And that's what this represents here. We're looking at it now on the inside. There's the hole. This artery here is called the sphenopalatine artery. It is the termination of the maxillary artery. Remember the maxillary artery comes across here like this, goes all the way up here and dives through that hole to enter the back of the nasal cavity. Once it dives through the hole, called the sphenopalatine foramen, it now becomes the sphenopalatine artery. V2 branches also go through that hole over here. The nerve is called the the nasopalatine nerve. So it's the sphenopalatine artery that supplies the nasal cavity, nasopalatine nerve. And once they get into the nasal cavity, they branch all over the place. In this picture right here, you see them supplying the lateral nasal wall. But remember I was talking about posterior bleeds? That's the posterior bleed side. That's the end of the maxillary artery. You can obviously see how huge that could bleed versus these little terminal branches over here. Okay, so the artery and the nerve travel both on the lateral wall and on the medial wall, because this is the septum, towards the front of the nose, supplying it along the way. And then the nerve, and that's the artery too, but the nerve will dive through that incisive canal. The nerve dives through the incisive canal right there, because they're inside the nose, right? They're going forwards. That nerve dives through the incisive canal, comes out on the tip of the hard palate as the incisive nerve, and supplies, since it's trigeminal, it's sensation, right? Somatic sensation. So if you ever had your incisors worked on by a dentist, they're going to go through here to anesthetize to get the anterior superior alveolar nerve. So the next thing they're going to do is take that needle and stick it into the incisive canal. They're going to poke around on your hard palate until they find the opening of the incisive canal, and then they're going to inject lidocaine right there to make sure that the back, the lingual gingiva is anesthetized, that they're going to do something with that too. Let me tell you what. Has anybody had that done? When they hunt for that nerve, you will form tears.
Yeah.
It is the most painful thing to take that needle and bounce it along the hard palate until they find that canal.
Yeah.
We got some amens on that one, right?
Amen.
Yeah. And you know, the thing is, The dentist that you guys are gonna meet and the dental hygienist, Edith and Dr. Bath, they are the nicest people in the world. But, I mean, the guy that did that on me, I mean, he was the Antichrist. Yes, ma'am.
Did you say the maxillary alveolar branches of V2 provide visceral efferents as well?
It translates them. Remember,
Oh, because it like goes with the.
right, so what what cranial nerve are those visceral efferents gonna be from?
The facial.
7, yeah, the 7. 7 gets everything except the parotid gland, and that's 9. So there are 2 things you can almost take to the bank. One is whenever we talk about sensation, it's 5. Whenever we talk about visceral efferents, the motor supply to glands of the head, it's 7, except for the glossopharyngeal.
Did you specifically name that nerve coming out of the incisive canal, or was that just an
It's called the
extension of the nasal?
incisive nerve.
Okay.
Yeah.
But you said the somatic sensation for the tip of the tongue, right?
That's the trigeminal. We're gonna talk about the tongue here in just a second.
So it has both sensation and motor, both visceral? Sorry, I'm-
To the tongue,
yeah.
the tongue is hypoglossal. We'll talk about that later on. As a matter of fact, the tongue is innervated by 5 cranial nerves. So just hold your horses here for a second on that, okay? There is a slide on that. All right. The mandible you've been over here, you got the mandibular knot, you got the coronoid process, the condylar process. On the inside, you've got the mandibular foramen. This is illustrating the pathway of the inferior alveolar nerve. The mental foramen is what comes out the end here. This is a non-Oklahoman cadaver because it's a mandible with teeth. So with teeth, what's Spanish for teeth? Dientes? Okay, so this is mandible con diente, right? Which reminds me, I got home last night, it was before the 10:30 thing. I got home last night and my wife had made this tilapia. She got this tilapia and breaded it and was cooking it. And she made this sauce with minced garlic. And man, that was good.
Drop back in.
It really was good. With asparagus. And then she got this big loaf of bread. I don't know where she got this bread, but it was really
We're
good
all
too.
eating before dinner.
All right, so what we've done in this illustration here is we're looking at the mandible. We've removed the tongue. Are you feeling better today?
Yeah,
Okay, you're not coughing, so you must be better.
yeah, I know.
We've removed the tongue here, and the tongue, the root of the tongue muscle is called the genioglossus. That's the tongue muscle. The intrinsic muscle of the tongue is the genioglossus. So we just cut the tongue out. Underneath the genioglossus is this cylindrical geniohyoid. We've mentioned that muscle before. And deep to that is the malahyoid going from side to side. So that's looking at the floor of the mouth from above. And of course, if you go in the other direction, you're going to hit the malahyoid first, and then the geniohyoid, and then the genioglossus. Okay. In the floor of the mouth, though, there are 3 structures that are pretty impressive. One, here's our submandibular gland. The duct comes out of the gland. Got the glare on the thing again. There's the duct right there, and it comes out right there at the little gleek, the carbuncles of beside the frenulum. We'll see it later on. So it opens up right there. You can look at each other. It's pretty easy to see. I mentioned the other day submandibular and sublingual salivary glands. These are the sublingual salivary glands here and there. They don't have a single duct opening into the floor of the mouth. They have like 10 to 14 small duct openings. So you really can't find those. The two ducts that you can find are Stinson's duct from the parotid and Wharton's duct from the submandibular. Keep in mind, though, that if you get infection of the salivary gland, it involves the sublingual salivary gland, you're going to have swelling along the floor of the mouth. Now, you can see, if you look in each other's mouth and lift up your tongue, you can see a ridge right here. That ridge is, underneath that ridge, what's forming the ridge is the sublingual gland. And the ducts drain into the top of that ridge. So you need to look in each other's mouths to see that. Yes, ma'am?
Sorry to go back, but if we have a blockage or infection of Stinson's duct, I know we talked about Wharton's, but how would you clinically treat that if you have a blockage of Stinson's duct?
If you had a stone somewhere in the duct, it's the same way. You give them lemon drops.
So for both?
Yeah, either one, yeah. You don't, if they don't, what you do is you give them lemon drops and put heat on the area. The heat will tend to dilate the duct. Give them a day or so. You might need to give them some pain medicine because it is painful. If they don't pass the stone on their own, then I would send them to an ENT and let them endoscopically go in there and snare it and pull it out. Okay. Most of the salivary gland ducts calculi are radio opaque. In other words, you can see them on X-ray. Now, crossing underneath the duct here, you're going to find the lingual nerve. The lingual nerve comes in, it's in the floor of the mouth. The lingual nerve. The hypoglossal nerve, supplying the tongue itself, is way back here in the back. You can see in this illustration right here, the lingual artery. You see it running on the floor of the mouth. We're going to see, I'm going to show it to you in different angles later on. The alveolar nerve, I want to beat this horse to death. You see it running inside the mandible, giving its fibers up to the roots of the teeth. The tooth has to stay innervated in order to stay alive. If it becomes denervated, then you have to do something to preserve the tooth. And a root canal is the action of going in there and essentially drilling out the nerve from the roots of the tooth. So you kill the tooth. That's why a root canal is typically followed by destruction of the tooth. They grind the tooth down and put a cap on top of it. It's very unusual for them to do a root canal. Does anybody have a root canal without a cap? Yeah, you pretty much have to destroy the tooth and put a cap on it, because once it's denervated, the root will start to reabsorb. So, I put this in here because this has always fascinated me. When you look at the mouth of a child, this is a normal mouth of a child. Because their larynx is up so high, their head is sort of squashed. When they say ah, you can typically see the tip of their epiglottis in the back of their mouth. It sticks up actually quite high. It's truly impressive. If you've got little kids, nieces and nephews at home, get them to open their mouth, maybe put your finger on their tongue to hold it down a little bit, get them to say ah, and you go, wow, that's huge. Occasionally, you'll have a parent come in to say that my kid has a tumor in the back of their mouth. In fact, it's the epiglottis. Epiglottis we see down here in the adult. It's much more caudally placed because of the changes in development. All right, here's the genioglossus right here. There are all types of fibers of the genioglossus. There are radial fibers, there are horizontal fibers, transverse fibers, because the tongue is able to do huge versatility. Interesting, in case you haven't figured it out yet, there must be a relay in your brainstem. There must be connection in your brainstem between the proprioceptors of the TMJ, which would be what cranial nerve? 5. Proprioception is sensory, right? So there must be a connection between the proprioceptors at 5, knowing where that your jaw is open or shut. What innervates the muscles of mastication? Trigeminal. So there must be a connection between the sensory component of 5 and the motor component of 5 that are the different parts of the brainstem. What keeps the food between the teeth? What innervates that?
Mucinator.
7.
What cranial nerve? 7. What moves the tongue up and down? What innervates the tongue? The hypoglossal, 12. So there must be some type of reflex or relay between 5, 7, and 12 so that you don't wind up eating your tongue. It keeps, when you chew, you reflexively keep your tongue out of the way. When you bite your tongue by mistake, you just were running your mouth faster than the nerves can move it out of the way. Okay? All right. Inferior to the genioglossus is the geniohyoid, and below that's the mylohyoid. What's that opening into the back of the nasal cavity? The choanal. That's the choanal. This would be the opening into the trachea. That's the esophagus. There. There's the posterior wall of the pharynx. Prevertebral fascia. Okay, we're going to see that in just a second. But for right now, let's go a few more slides. This is the tongue, looking at from the dorsal surface, along with the epiglottis in the back. There's the palatine tonsils with the palatoglossal fold and the palatopharyngeal fold. If you look at the surface of the tongue, if you take a towel and dry the top of your tongue off, it's truly impressive, the little things that pop up. If you haven't done that, I would encourage you to do that and look at it in a mirror. It is really a nasty looking thing. Back in the very base of the tongue, back where the epiglottis is, there's lymphatic tissue. The palatine tonsils are lymphatic, with lymph, right? The lymphatic tissue on the base of the tongue is called the lingual tonsils. Palatine tonsils, lingual tonsils. In front of the lingual tonsils, there's a V-shaped structure here made of these large, round papillae. Those papillae are called circumvallate papillae. Circumvallate papillae. They have little grooves around them, and you find tons of taste buds in those grooves. They're also called vallate, circumvallate or vallate, whichever term you want to use. What have you been doing right here? Oh, the stuff on the floor? All right. What's that? Okay. You follow those V's to the V back, there'll be there's a pit right here. That pit is called the foramen cecum. That's where your thyroid started. The pit is, the foramen cecum is at the point of the V, in the vallate papillae. Now, out in this part of the tongue, when you dry it off, these things stick up, and they're very rough. Not like a cat's tongue, but they're impressively rough. there are two types of little papillae on the anterior part of your tongue. There are these little nodular ones that look like mushrooms, hence the name fungiform. Tons of taste buds on those fungiform papillae. And then you have little finger-like projections. These are called filiforms. The filiforms are very they're high in sensory receptors, but not taste buds. There's a median groove in the midline where some freaky people will go in there and have their tongue cut right here. In a non-surgical, like they go to the tattoo place, the piercing shop, they have their tongue sliced in the middle. And when it heals, now you have a forked tongue that they can move the sides independently. It is the most freaky thing. Do the YouTube thing on people with split tongues. It is just bizarre. Any questions about that? There are extrinsic muscles that work on the tongue. We know genioglossus, which is below the genioglossus is the tongue muscle. We know geniohyoid, which is this one here. There are muscles, other muscles that come in from the back. The palatoglossus, styloglossus, hyoglossus comes from the hyoid bone up. We're not going to really find those in lab, but understand that there's more than just the tongue muscle that aids in its movement. They're all innervated by cranial nerve 12, except the palatoglossus. That's the only one that's not. What's that?
How do you spell that?
Palatoglossus, like a palate and glossus. It's on one of the previous slides. The innervation of the tongue, I said there were 5 cranial nerves. Somatic sensation to the tongue, the anterior 2/3 of the tongue, is by 5. Somatic sensation to the back of the tongue is by 9. So the anterior 2/3 is 5, posterior 1/3 is 9. Motor to the tongue is 12. There's the palatoglossus right there. The taste buds in the anterior 2/3 are innervated by what nerve? Chorda tympani of 7. Taste buds to the posterior 1/3 are innervated by 9. And then there are taste buds back here on the epiglottis and at the base of the tongue. They're innervated by 10. So we have 5 cranial nerves that go to the tongue. Here are the lingual and hypoglossal nerves. There's a hypoglossal nerve with its ansa coming off of it as it enters the back of the oral cavity. The lingual nerve is up here, deep into the floor of the oral cavity. I think today in lab, I'm going to bisect one of the heads so we can see the oral, I'll shell out the floor of the oral cavity so you can see these nerves internally. Does that help when I do these extra dissections and you can see it like that? Okay. You'll also find the lingual artery, and there, the lingual artery supplies everything on the floor of the mouth. On the tongue, the inferior part of the tongue, there's the frenulum. Here are the two little carbuncles for the submandibular glands. That sublingual fold is where you'll find the sublingual gland. If you peel away the mucosa, you'll see all those nerves and blood vessels on the deep surface of the tongue, coming in from both sides. The lingual nerve is here. And one thing I wanted to show on this slide right here is that little ganglion right there. That ganglion is the submandibular ganglion. So visceral efferents go into the submandibular gland, and the sublingual gland will synapse in that submandibular ganglion. It's a visceral efferent ganglion, right? What cranial nerve is it associated with? 7.
Where did they go? So.
Yeah, so it's the visceral efferents, it's a 2-neuron system, right? So they start out in 7 in the brainstem, the preganglionics. They're going to ride with cranial nerve 5. There's a chorda tympani right there. I think that's the chorda tympani. Yeah, there's the chorda tympani right there. Joins the back of the lingual nerve, so the preganglionics are in there. They're going to synapse in that submandibular ganglion, and from there, the little fibers will come out to innervate the glands with the second neuron in the chain.
Which two glands?
Submandibular and sublingual. So, if we summarize, and then we'll take a break here. Sensory, visceral efferent. And we're talking ganglia here. You know that the sensory ganglia, or the dorsal root ganglia, right? The trigeminal ganglion. This is for your body, that's for your face. The visceral efferent ganglia. So the visceral efferent ganglia for the sympathetics we know are chain ganglia and pre-aortic that we're going to see next block. But when we're talking about visceral efferents of the head, sympathetics would get to the head through the chain ganglia, cervical chain ganglia. The parasympathetic visceral efferents are going to be associated with 3, 7, 9, 10. Well, 10 is that, so we're not dealing with 10 visceral efferents in the head. So let's look at the other 3. The third nerve, the oculomotor nerve, goes to the eye. What's the ganglion associated with the eye? Ciliary. What's the ganglion associated with the with 7? Right. So this ganglion right here what's that? What'd you say?
I said chorda tympani.
The chorda tympani is the nerve.
Yeah.
So, submandibular, and then the ganglion of 7 go into the lacrimal gland. So this is the ganglion of V3. The lacrimal gland's up here. We're not going to use this ganglion to get to the lacrimal gland. What ganglion sits up here? That's that one that I just showed you, the pterygopalatine ganglion will get you to the lacrimal gland. And the only visceral efferent ganglion that would be left would be 9. We've got 10, the vagus goes down here, not in plane here. 3 goes to the ciliary, goes to the